thank you for your kind invite and your kind words. So I'm grateful and I'm thankful for this opportunity because at least I know that it should change some of the audience's practice, especially when it comes to these patients, which I feel are neglected. I think I'm ready to start. I'll just quickly stop my camera and we can start. So Dr. Mawela, I'll be sharing my screen. Like I said, if you look at the topic, it says chronic venous insufficiency, but I opted to change it to chronic venous disease because that's a more encompassing term to use, as you'll see based on the definition, because chronic venous insufficiency basically refers to patients who already have advanced disease. You can move on. So I don't have any disclosures to make for this specific talk. And on the next slide, you'll notice the brief contents that we'll go through. We'll touch on anatomy, right down to pathophysiology, the presentation, the investigations that are appropriate for these patients, and the treatment options. And I'll quickly share 2 clinical cases that we've recently treated. We can move on. Now, most of you will recall that the anatomy of the lower extremity, the venous anatomy, you have the superficial venous system, you have the deep venous system, and these are connected by perforating veins. Now, the superficial system, the truncal vein, is what mostly people will be aware of, is the great saphenous vein, which starts just anterior to the medial malleolus, running up and to join the deep venous system in the saphenofemoral junction. Now, posteriorly, you have the small saphenous vein, which starts just behind the lateral malleolus, runs up between the heads of the gastrocnemius muscles to join the popliteal vein at the saphenopopliteal junction. You can move on. Now, the deep venous system, these actually accompany the arteries. So they are similarly named, except for the femoral vein, which was what previously known as the superficial femoral vein. But like I said, these accompany the arteries. Then you do get these perforating veins, which in the past were really given some difficult names. So you had Hunter's perforator, you had Dodds, you had Boyd's, and Cocket perforators. But I'm glad with the new nomenclature, excuse me, we don't really have to use that. Now, we can move on. Now, looking at chronic venous disease, if you look at the vein term consensus document, they define this as any morphological and functional abnormalities of the venous system as of a significantly long duration, which manifest either by symptoms or signs which mandate investigation and or care. Now, the most common manifestation that people are aware of is that of varicose veins. And as you'll notice that 22% of patients with varicose veins will actually progress to chronic venous leg ulcerations in 6 years. And we all know that once the patients reach that stage of chronic venous leg ulceration, that carries with its significant economic and psychosocial impact, which results in poor quality of life. And not only that, if a patient has a chronic venous leg ulceration, their quality of life is said to be as poor as that of somebody who's got an advanced malignancy. So we need not look at this lightly. Can move on. Now, look at the variable manifestations of chronic venous disease. The majority of patients, just over a quarter of them, simply present with what you call spider veins or reticular veins or telangiectasia. Then the second biggest group is those who present with varicose veins. Now, these varicose veins, up to 19% of the patients with chronic venous disease have this, but more so in the European population. But in our African context, it is less common. Then just under 10% of these will present with unilateral leg swelling, which is chronic, and 4% develop these skin changes, which I'll allude to later on. And fortunately, the most severe forms, which is the venous leg ulceration, occurs rather in less than, or is seen in less than 1% of these patients. You can move along. Now, when you look at the pathophysiology, now, it's predominantly either valvular incompetence which results in reflux, especially in the superficial venous system. Yes, it can occur in the deep system as well as in the perforating veins. So as you can see on the top left picture, you'll notice a healthy vein which has valves that are competent and they only encourage unidirectional flow of blood towards the heart. Now, with an unhealthy vein or the valves there are incompetent, so you do get retrograde flow. And this unfortunately will result in chronic venous hypertension and the long-term sequelae that we have that I've alluded to. Now, the other important pathophysiological mechanism is that of an obstruction. Now, obstruction may occur as an extrinsic compression, as you can see on the top right screen, where the right common iliac artery compresses the left common iliac vein. And that's called the Meitner syndrome. And it's quite common, and you'll see as well as on the patients that I will quickly share later on that these patients also had this Meitner syndrome. Now, obstruction may also occur as a result of a previous deep venous thrombosis. Now, a DVT results in endothelial injury as well as valvular injury. So as a result, these patients will develop reflux from the previous DVT, and they may also develop significant sclerotic lesions or trabecular and spurs that may cause an obstruction to the venous outflow. So in simple terms, pathophysiology is usually incompetence of the valves or an obstructive lesion or a combination of the two. We can move on. Now, the clinical manifestation is quite variable. Now, these patients may complain of leg swelling, leg heaviness, complain of tired legs, thrombing, burning pain, even nocturnal cramps, complain of skin symptoms like itchiness, or some may even present with what you call venous claudication. Now, venous claudication by definition is a bursting type of a pain or a fullness which is noted in the lower extremity with exertion or with walking. But this pain is usually improved by rest with limb elevation. And that is a sign or rather a symptom in keeping with venous outflow obstruction. So whenever patients present with such symptoms, you need to really consider that. Some may complain of aching of the legs, which is particularly exacerbated by prolonged standing or sitting. And you do get a significant portion of patients who are asymptomatic. Yes, okay, thank you. Now, when one goes through the history of this patient, you need to consider the risk factors. Now, female gender, unfortunately, is a risk factor for this disease. Advanced age and obesity, there's clear evidence to suggest that obesity is a significant cause of coronary venous disease. Now, occupation, which is related to, or rather where there's prolonged standing, excuse me, is another risk factor. Now, family history is one other component that you see quite often. And in terms of parity, so the higher the parity, the higher the risk. Although there's no clearly defined number of pregnancies that will put a patient at risk, but the mere fact that you've been pregnant once, that is a risk factor on its own. Now, previous DVT, like I had said, is when these patients develop chronic venous disease as a result of a previous DVT. We call that a post-thrombotic syndrome. We can move on. So those are the risk factors to look out for. Now, on clinical examination, there are a number of important things. Yes, we'll assess the patient generally as one would under normal circumstances, but these patients should be examined in the standing position because this is where the clinical, the signs will become more apparent. What you're seeing on A there is a patient who's got reticular veins. So reticular veins are typically veins which measure between 1 to 3 millimeters in diameter. Or they have what you call telangiectasia. Now, telangiectasia These are veins located in the dermis. They measure up to 1 millimeter in diameter. And images B and C clearly depict varicose veins, which I think all of us are aware of. Picture D, that's a patient who's now got unilateral leg swelling on the left-hand side as a result of this. Then as you move on to the more severe disease, picture E, that's when they start developing these skin changes. Now, these skin changes may be typically skin hyperpigmentation, they may have eczema, or they may have what we call lipodermatosclerosis. Now, lipodermatosclerosis is a thick, leathery-like skin, and it is a clinical sign in keeping with advanced chronic venous disease. Now, on image G, that's a patient with a healed venous ulcer, and H is somebody who's got an active venous ulcer. But I just want to explain something about these venous ulcers, especially in terms of their clinical presentation. Now, venous leg ulcerations typically occur over what you call the gaiter area or the distal third of the leg. They're usually over the medial malleolus, and they tend to be quite shallow. Their edges are irregular, and they are very exudative. So these patients will complain that their bandages tend to get wet quite often. And lastly, you will pick up other clinical signs suggestive of chronic venous disease. Can move on. Now, you need to assess these patients for potential suprainguinal disease as well. Now, this may be seen as cross-pubic collaterals as depicted in the picture on the bottom right of the skin, or you see abdominal collaterals. Now, when you see abdominal collateral veins, the first thing that comes to mind should be the possibility of an occluded or obstructed inferior vena cava. But if you see them on the one side, then that is suggestive of an occluded venous outflow from the iliac veins. You also need to check for valvular varicose veins. Now, these you see especially in patients who have pelvic congestion syndrome, and this may be a sign of suprainguinal or venous disease coming from above the inguinal ligament. Importantly, these patients must be assessed for presence of peripheral arterial disease. This may include simply examination of the pulse status, because if a patient has palpable pulses, then clearly that patient doesn't have peripheral arterial disease. The second thing that you can use to assess and give you an idea of the severity of the PAD, if the patient has it, is the ankle brachial pressure index. Because an ankle brachial pressure index of less than 0.9 is diagnostic of peripheral arterial disease. We can move on. And later on, I'll explain why it's important to assess for the PAD. Now, some patients may unfortunately present with acute complications of the disease. And these may include superficial venous thrombosis, where patients will complain of a severely painful area over the lower extremity, typically over the great saphenous vein distribution. And they'll usually feel a tender, it's almost like a cord that they have. And that is typically treated with anti-inflammatories and even anticoagulation, depending on its extent. Now, some patients may present with bleeding varicose veins. Fortunately, these are usually not life-threatening, and simple compression should suffice. But once they start bleeding, that's an indication that something more aggressive needs to be done, not compression alone. And I'll explain this a little later on. We can move on. Now, to grade the severity, really we use these grading systems, which I don't think many of you need to worry much about. But if you look at them, this revised venous clinical severity score, it considers the presence of pain, varicose veins, if there's edema, skin changes, inflammation, induration, including the presence of an ulcer and the size thereof and the number of these ulcers. So depending on these, patient may be considered to have severe disease as such. Now, in patients who have post-thrombotic syndrome, firstly, to make the diagnosis of post-thrombotic syndrome, we use this Villalta score or Villalta scale, and a scale of 5 or more is considered diagnostic. It involves a number of symptoms, a number of clinical signs, and any patient with a score of 15 or more is considered to have severe post-thrombotic syndrome, or if there's a venous leg ulceration. We can move on. Now, once one has done this clinical assessment, some of you may be aware of other clinical signs that may be elicited, and these would include things like your Pettis test or Trendelenburg test, but those are really for historical interest. They are non-sensitive, sorry, they're non-specific, and they have poor specificity, so we don't use them in clinical practice. Now, then we'd move on to the duplex ultrasound, and this is the #1 investigation of choice, and based on it, you may continue or proceed to treat the patient without further investigations. Now, it will tell you about the venous anatomy, whether the veins are patent or not, whether there's flow, and you're able to assess for reflux. And reflux is usually provoked. We ask the patient for a Valsalva maneuver, and you check the duration of the reflux, because you do get physiological reflux and pathological reflux. Now, you're also able to measure the diameter of the veins and the course thereof. And these are of clinical relevance when it comes to the treatment of this. As you notice, the venous duplex ultrasound should be done with the patient in a standing position, because that's where you get accurate information. Okay, we can move on. Now, you do get some patients who present with the recurrent varicose veins. Now, meaning they've had previous treatment for varicose veins, now they come with the recurrence. And a duplex ultrasound is a very good tool to give you an idea of the cause of this. Now, if a patient has had previous endovenous ablation, you may pick up recanalization. If they've had previous vein stripping, you may pick up the presence of neovascularization. And we would only do the abdominal ultrasound if we're suspecting that there's pathology above the inguinal ligament. You can move on. So like I said, a duplex ultrasound may be the only investigation you use, but we may use cross-sectional imaging, particularly where the duplex ultrasound is inadequate or where this is not feasible, because a duplex ultrasound may be limited by the presence of excessive bowel gas when you do it, and especially in an obese patient, you may not be able to get adequate information. So our options there becomes the magnetic resonant venography, which would clearly show deep vein obstruction if there's venous scarring, the presence of collaterals, and even varicose veins. A CT venogram is another option where you can offer patients a direct CT venography or indirect CT venography. Now, a direct CT venogram is when you inject contrast within the dorsal vein of the foot, and the CT scan is done after that injection. That's more direct because it takes the natural course of the venous flow. An indirect one is where it's injected, especially in the upper extremity, and the patient has what we call a venous phase on the scan. But really, these are more useful for assessing the suprainguinal area where you're suspecting an obstruction or anything of that nature. You can move on. Now, other investigative tools include the conventional venography. Now, conventional venography is where you actually puncture the vein itself, you gain access within the vein, you inject contrast in an angio suit or a cath lab, and under fluoroscopy, you're able to assess the veins and not only assess, but potentially treat. So you get two types: an ascending venography, when the injection is injected from the distal aspect of the leg. This is useful for assessing obstruction of the venous outflow. Or you can do a descending venography, when the injection is given from, you'll usually access from the internal jugular vein, going right down to the common iliac vein, and you inject contrast there. So there shouldn't be any reflux that occurs when you do this. So this is used to assess for deep venous valvular incompetence. But like I said, these are not used purely for diagnostic purposes because they are quite invasive and the patient needs to go to theater. So we usually use them when we're offering patients intervention as well. We can move on. Now, there's this tool is new in our setting. I mean, a developing country, but it's not necessarily new. This is what we call an intravascular ultrasound. So this is where you introduce an ultrasound probe within the venous system, and you're able to assess and determine and quantify the level of disease more accurately than any of these other investigations that I've discussed. Now, you're able to assess for and identify very subtle intraluminal changes and vein wall abnormalities. And like I said, it's far more sensitive than venography. We are quite fortunate in our institution. We do have this, and the examples I'll share later on, I will show the images of this as well. We can move on. Now, once we've assessed the patient clinically and on imaging, then we use this CEAP classification to classify these patients. Now, C stands for the clinical component. You either have C1 right up to C6 disease. C1 being those patients who have this reticular vein or telangiectasia, and C6 being the most severe form where a patient has an active ulcer. Now, the E stands for the etiology, whether the disease is primary, where there's no identifiable cause, or it's secondary to some form of compression, whether it's extrinsic or intravenous or congenital. And anatomic, we check here whether the disease is in the superficial venous system, the deep venous system, or the perforating vein. And lastly, I spoke about this before, the pathophysiology, whether the patient's symptoms or disease is as a result of reflux or obstruction, or a combination of the two. I know it looks a bit complex, but it is quite useful when we decide on the treatment and the treatment modalities. We can move on. Now, once you see a patient with a suspected chronic venous disease, firstly, you'll take history, you'll examine the patient, and like I said, your next investigative tool will be a duplex ultrasound. And based on this, the patient may have no chronic venous disease, so patient must be investigated for another cause of the symptoms. Or a patient may have chronic venous disease, however, a patient may not be a candidate for intervention. There you'll consider conservative treatment alone. But if the patient does have chronic venous disease and they're a potential candidate for intervention, if they only have infrainguinal disease, meaning the disease is below the inguinal ligament, if it's the superficial venous system that is diseased, you can treat that. If it's the deep venous system, then mostly we'd use conservative treatment, not operations, or you may consider treating them. This is in very selected high volume centers that may consider things like valvular transplantation or valvular reconstructions. And I don't think anybody does that in our country. But if you're suspecting disease above the inguinal ligament now, there you start with the duplex ultrasound, but you'll also include the abdominal component. And you may consider doing an MR venography or CT venography. And depending on the findings, you'll treat the patient. And I'll explain this later on. You can move on. Now, if you're treating a patient with chronic venous disease without an active venous leg ulceration, really one needs to offer this patient a holistic approach. And the reason for this is there's no one intervention that will cure the patient. So this involves certain physical methods. The patient needs to be encouraged to exercise. Now, the aim for this is you want to improve the patient's, or rather the limbs muscle strength, as well as ankle mobility. As you'll recall, with ankle mobility, you get usage of the calf muscles. Now, the calf muscles are considered the heart of the venous system. So if you don't use your calf muscles, then probably those patients will develop chronic venous disease. So that's one of the first few things that you need to address. Now, physiotherapy is critical, and this aids the patients with general mobility. For your obese patients, they need to lose weight. And limb elevation is one of the very simple maneuvers that work quite well. You can move on. Now, in addition to those physical activities, there's certain lifestyle modifications that the patient need to embark on. They need to take frequent walks, avoid prolonged standing whenever this is possible. And if they have to stand, then they must at least move. And by that, you encourage your calf muscles, so that you reduce the risk of this chronic venous disease or even improve the symptoms. I've mentioned the fact that they need to rest with their limbs elevated and avoid heat exposure. Now, heat exposure results in vasodilatation. Now, with vasodilatation, that will result in increase in venous hypertension, and that will worsen the symptoms. Can move on. Some part of the conservative treatment, but the next step would be to offer this patient compression. Now, compression comes in many different forms. You can have elastic compression stockings, or what we sometimes call the graduated compression stockings. As on the picture on the bottom right of the screen, these graduated compression stockings, they have the maximal pressure over the ankle joint, and the pressure decreases as you go up towards the calf. And this serves to encourage flow towards the heart. Now, some of you may be aware that these in the past were usually described in different pressures, like class 1 compression stocking, class 2, class 3, but we've moved away from that now. We actually, when you are treating the patient, you must prescribe what pressure you want. But I'll talk about pressure in a moment. Now, you also get these adjustable compression garments on the bottom left side of the screen, and very seldom patients who can afford this can use intermittent pneumatic compression. So compression is very critical, and in my opinion, it is the mainstay of treatment here. We can move on. Now, some may question now, how high should the compressions be? Knee high or thigh high? Really, there's no evidence to suggest that any is better than the other. But whenever a patient has edema or swelling that extends above the knee joint, we would consider using thigh compression stockings, thigh high compression stockings. Or in a patient who's had intervention, especially from those endovenous thermal ablation, you'll consider that, or in patients who have post-thrombotic syndrome with venous claudication. So those ones we consider thigh high compression. Now, there's usually a huge issue around compliance with these patients, because with heat, really most patients can't tolerate this. It's very difficult to wear and take these off, and some patients really are unable to wear these or take them off because of other comorbid issues. Obesity is another challenging thing. So companies have devised these donning and doffing aids in order to mitigate against this and improve compliance. Now, compression stockings, rather compressive therapy, is contraindicated in very few patients. Patients who have severe peripheral arterial disease, where the ABI or ankle brachial pressure index is less than 0.6, or those who've had previous bypasses where sorry, I was just reading the comment there, or the question. But anyways, those patients who've had an anatomical, so a bypass where the graft was placed just under the skin, or patients who are in heart failure, or those who have allergy against any of the materials that are used. And any patient who has significant peripheral neuropathy, because they may not appreciate the severity of, if the compression is excessive and they actually need to take them off. So we would really not use them in those patients. We can move on. Now, in a patient who's for conservative treatment without an active ulcer, really exercise, number one, and lifestyle adaptation, compression therapy. And if the patient just simply has some venous symptoms, compression stockings with a pressure of at least 15 millimeters of mercury would suffice. Those who have edema, you need to take the pressure slightly higher to 20 to 40 millimeters of mercury. And those who have severe skin changes, you need to have a higher pressure. Most people will say you need at least 40 millimeters of mercury. Now, your orthotists, I know not all institutions have orthotists, but they are the people who are able to offer this to patients, and they can even make custom-made compression garments or stockings, which will give the required pressure. I'm not going to talk much about pharmacotherapy because most of those drugs are not available in the country and their effectivity is not that well established. We can move on. Now, when you're dealing with a patient who has superficial venous incompetence, they may simply be patients who have reticular veins or telangiectasia or varicose veins which are asymptomatic. Really, those are mainly a cosmetic issue and no intervention is needed for those patients. But I know most of these patients don't buy that story. So unfortunately, you need to stand your ground because it's usually a cosmetic issue. Some of them will even make up the symptoms just to get some form of treatment. But unfortunately, that's what we have to deal with. Now, those patients who have symptomatic varicose veins, or those who present with complications of varicose veins, or those who have severe disease, by that those with edema or skin changes do require intervention. Let's move on. Now, there's a number of options when it comes to these interventions. Now, I'll start with the old technique. Now, this is what was called the Trendelenburg procedure, which is the high ligation and varicose vein stripping. So what we do is we expose the saphenofemoral junction at the groin, and we insert what we call a stripper. So it's a piece of instrument, and we take it out at the level of just above the knee joint, and we simply strip off the vein. We remove it, the great saphenous vein. Now, if this great saphenous vein was incompetent, or rather had incompetent valves, and was the cause of the chronic venous hypertension, if you've removed it, then the patient's symptoms will be addressed. And you'll notice that not all varicose veins will be in this distribution. So to remove varicose veins on other areas of the leg, we'd use sometimes what you call the step phlebectomies. Step phlebectomy is where you make a small incision, half a centimeter. You pull up the varicose vein with a mosquito or a hook, and you simply strip it off. But this is quite an invasive and an aggressive way of doing things, and we tend not to use this in this current days. We can move on. So what we'd offer patients now is these endovenous interventions. Now, these endovenous interventions are either thermal modes, and the most widely used are the radiofrequency ablation or endovenous laser ablation. But you do get others, but their effectiveness has not been well proven, like your endovenous steam ablation, endovenous microwave ablation. Now, these require tumescent. Now, tumescent anesthesia is basically when you apply an anesthesia, and in this case, we use ice cold saline mixed with marcaine with adrenaline, as well as sodium bicarbonate, soda peak. So the soda peak is just to make sure that when you inject these patients, it's not as painful. Now, what this does, you inject this around the vein under ultrasound guidance so that you compress the vein. So that when you burn, or rather use this thermal ablation, you don't burn the surrounding soft tissues and the skin. Now, there is these non-tumescent modalities which use sclerotherapy or glue, or even a combination of these. These are not as effective, so we tend not to use them. Let's move on. I'll just briefly describe radiofrequency ablation and endovenous laser ablation. Now, on the top left, top left part of the screen, that's an example of a procedure where they're using radiofrequency ablation. So you get a catheter which has a 7 centimeter long tip, and you access the great saphenous vein via a sheath, which you can see on the proximal leg on the medial aspect, and we start burning the vein endovenously or from within 2 centimeters from the saphenofemoral junction. Now, this emits heat of up to 120 degrees. So what you do, you cause this thermal injury to the vein, and that obliterates the vein heals by fibrosis, so there will be no flow in that vein anymore. So you would have addressed the source of the incompetence and the cause of the venous hypertension. And the venous laser ablation, very much similar principle. You access the vein, you start ablating about 2 centimeters from the saphenofemoral junction, and you move your way down, you get thermal injury and subsequent obliteration of the vein. You can move on. Just looking at my time, I need to finish in the next 5 minutes. Now, these endovenous thermal ablation techniques are used in patients who have reflux in the saphenous vein trunks, those being the great saphenous vein or the small saphenous vein. And you can also use it in the saphenous vein tributaries. But these are contraindicated in patients who have superficial venous thrombosis or those who have deep venous thrombosis or significant peripheral arterial disease. Now, the size of the great saphenous vein is important. Now, in our institution, any size great saphenous vein of less than 3 millimeters, we consider it too small for these techniques, and it is unlikely to be the cause of the patient's symptoms. So we wouldn't use these techniques for those patients. But I know in Cape Town, they use a cut of 4 millimeters, but in literature, they use mostly 2 millimeters. Now, in patients who have excessive tortuosity of the veins, it becomes technically almost impossible to do it. And if the vein diameter in the past was more than 12 millimeters, most would say, no, that vein is too big. The patient will be best served by high ligation and vein stripping. You can move on. Now, the complications of these, fortunately, they're non-significant most of the time, and they're self-limiting. And the last one, EHEAT. The EHEAT stands for endovenous heat-induced thrombosis. It's essentially a DVT because of these modalities. Fortunately, it's very rare, and really in our practice, we've not seen this, but it is something that we are aware of. Can move on. Now, endovenous laser ablation, the complications are very much similar to those of radiofrequency ablation. You can move on. Now, if you look at the guidelines, and these are the guidelines we use, these are the 2022 ESVS guidelines on chronic venous disease. Now, these guidelines actually recommend the use of endovenous thermal ablation as the first choice of treatment, in preference to high ligation and stripping, or even those other non-thermal modalities. You can move on. So this is the way to go. Now, if you have a patient who has superficial system disease, these guidelines would suggest that endovenous thermal ablation is your starting point, and you can use high ligation or other modalities if the patient has a contraindication to this. But if the varicose veins are from the great saphenous vein tributaries only, and the actual great saphenous vein is normal, there you can use step phlebectomies where you simply remove the varicose vein, or you can use sclerotherapy preferably use this ultrasound guided foam sclerotherapy. Can move on. Now, the deep venous system now, because what I've described is treatment for the superficial venous system. Usually you find there's an iliac vein outflow obstruction. Now, if a patient has this and they have C3 to C6 disease, now C3 is when they have unilateral leg swelling, or C6 is when the patient have venous leg ulceration. So if they have any of these, they require treatment. Those with post-thrombotic syndrome with moderate or severe disease need treatment, and those who have venous claudication. Let's move on. Now, in terms of treatment, you get many other causes of venous outflow obstruction, but the one that I'll be referring to here is those patients who have a May-Turner syndrome, which we've defined as extrinsic compression of the left common iliac vein by the right common iliac artery, or those who have post-thrombotic syndrome. The others, the treatment becomes a little different from what I'm going to describe. Let's move on. Now, I'll give an example of this lady we treated last week, Friday. It's a 59-year-old lady with chronic venous disease, and she presented with left-sided C4A disease. Now, C4A means she had skin hyperpigmentation, and she had a Venous syndrome, which we saw on a CT scan. And that's the picture of the leg. You can appreciate the swelling and the skin hyperpigmentation. You can move on. So we took this lady to theater and we did a venogram. That's what you notice on the bottom left image. And we injected contrast from below, going right up. So you'll appreciate the iliac veins going right up to feel the inferior vena cava. Now, when you look at this image, it looks essentially normal. But we went on to use intravascular ultrasound. The image at the top shows the common iliac vein, which appears normal just before the confluence of the right and left common iliac veins. So there appears to be no disease. But the bottom right side of the screen, what you're seeing with at the center there is the probe of the intravascular ultrasound. And to the left of the screen of that image is the right common iliac artery. If you can just point there, Dr. Mawela. So yes, what you're pointing at now is the left common iliac, the right common iliac artery crossing over the left common iliac vein. And you actually don't even appreciate the vein because it is completely compressed by the artery. So this lady had a Venous syndrome. You can move on. So after that, what we did was we stented that area with the obstruction. Now, let's start with the intravascular ultrasound on the top left-hand side of the screen. Now, what you still appreciate towards the left-hand side of the screen is that right common iliac artery. If you can point for me, please. Move to the left. Move to slightly. Yes. So that's the right common iliac artery now. And if you move close towards the right-hand side now, you can actually appreciate the stent and the fact that now the vein is open. So we've relieved this obstruction. And this is a repeat venogram on the image at the bottom. And you can clearly see now that contrast is flowing a lot better. And the top one, top right image just shows the stent after we deployed it. So this lady's symptoms improved significantly and venous claudication symptoms have resolved. But we need to place them on anticoagulation because there's a risk of a TVT. Let's move on. I've gone slightly beyond my time, but I think basically the guidelines suggest that if a patient has a venous outflow obstruction, stenting is the way to go. That's the first choice treatment. We can move on. Now, let me touch on these venous leg ulcerations. Now, these are quite a challenge, and not only for the patients, but also for the healthcare workers. They carry significant psychosocial impact, economic burden, and a poor quality of life. Now, fortunately, a majority of these will heal within the first 12 months, and with just about 7% remaining unhealed after 5 years. But the problem becomes the high recurrence rate. Up to 70% of these will recur. And that's an example of a venous ulcer. Let's move on. Now, with these patients, a multidisciplinary team approach is vital. You need to control or rather address a number of things. The pain needs to be controlled. Now, using antibiotics and antiseptics really, unless there's a clear clinical infection, then you can use them. But if there's no infection, there's no point in using antibiotics and antiseptics. Now, mobilization, physical therapy, these are also critical because they do decrease the venous hypertension and the edema. Moving along. Now, in addition to these, you need to offer these patients compression. You can move to the next slide. You need to address the wound. Now, wound care, if there's an indication for debridement, you offer the patients as such. And the dressing that you need to use, really, there's no specific dressing that is shown, that has been shown to improve healing. So the type of wound dressing that you'd use will be based on the characteristics of the wound. For example, if you've got a wound with excessive slough, you would want to use a dressing that has a desloughing properties. That's just one example. You can move on. Now, another important thing is the compression that you need to use. And in these patients, this is the mainstay of conservative treatment, and it has been shown to improve ulcer healing. Your aim is for a pressure of about 40 millimeters of mercury in the supine position. You get many different types now. You can use a superimposed elastic compression stockings where the dressing is applied, but on top of that, you apply at least 2 compression stockings on top. Or you can use this multi-component, multi-layer bandaging. And this is an example, Pro 4. Now, it's got 4 layers. First, you'll dress the wound under as you would under normal circumstances, but apply this compression starting from the forefoot, going right up to the proximal leg. However, the disadvantage here is these are quite pricey, and each dressing session, is about 1,000 rands. And these dressings must be changed every week. So in a month, it works out to about 4,000 rands. Fortunately, in our institution, we have this available and we use it, and it's quite effective. And you can also use other modalities like your adjustable compression garments or intermittent pneumatic compression. Move on. You can move on. Now, just briefly, you do get patients who have mixed venous and arterial ulcers. Now, fortunately, this occurs in the minority of cases, and compressive therapy is permissible provided the patient's ankle brachial pressure index is more than 0.6, or the ankle pressure is more than 60 millimeters of mercury, or a toe pressure of more than 30. If these conditions are unmet, then the patient requires arterial revascularization first before the compressive therapy. You can move on. Now, let's just briefly look at 2 studies. And these 2 studies looked at patients who had venous leg ulceration as a result of superficial venous incompetence. So this is called the EVRA trial. It was a randomized controlled trial, and they looked at patients with superficial venous reflux with venous leg ulcers, and the randomized patients to compression with early endovenous ablation compared to those who were offered compression with deferred ablation once the ulcer has healed. Let's move on. Now, looking at the results of these, there was clear evidence that early endovenous ablation actually accelerated venous ulcer healing at 24 weeks. 85.6% in contrast to 25.4%, and this was statistically significant. And the other advantage was that early endovenous ablation actually showed that the recurrence was a lot less, which is a problem that I have alluded to earlier on. You can move on. Now, this was an earlier trial. Now, here they were still using this high ligation and vein stripping. And for the same group of patients, they used patients who had active or recently healed venous leg ulceration. Now, they randomized patients to compression alone or compression with high ligation and stripping of the superficial venous system. Now, in this Ashka trial, what they found was there was no difference in venous ulcer healing rate. However, at 4 years, they found that the recurrence rate was a lot higher in the compression alone group. So as a result, the guidelines have gone on to suggest that early endovenous ablation is recommended to accelerate healing. Not only that, but to also reduce the risk of recurrence. Next slide. Now, for the deep venous system in a patient who's got a venous leg ulceration, really those patients, venous stenting is the treatment of choice. I think I'm almost done. Now, if you've got a patient with a venous leg ulceration, yes, they need to be assessed, ideally by a multidisciplinary team, and you want to objectively assess the arterial system. You want to treat the cause of the chronic venous hypertension. If it's in the superficial venous system, then you ablate that. If it's in the iliac venous outflow obstruction, then you stent that. You also need to use compression therapy, and you may consider other additional interventions like mobilization to address things like ankle stiffness because you want to encourage calf muscle movement, and really no antibiotics if there's no infection. Next slide. Well, just lastly, this is a lady we treated on Wednesday last week, 39-year-old lady with the venous leg ulceration from post-thrombotic syndrome. As you can appreciate, she had quite bad disease. Next slide. So this lady, what you see on the left-hand side of the screen, you can see collateral veins. You see the inferior vena cava, but that iliac system or iliac veins were completely occluded. So we did manage to get across the occlusion if you look at the picture in the middle, and we got access into the inferior vena cava. And what we subsequently did, the top right image with balloon angioplasty. So we used a high pressure balloon to open up this vein. Next slide. Now, once we've opened it on the bottom left side, you can clearly see now that you do see some flow into the IVC from the external and common iliac veins on the left-hand side. Now, once we did this, we went on to stent this lesion, and this was our completion venogram on the right-hand side of the screen. And you can appreciate there's clear flow in that deep venous system now. Next slide. I think to conclude, my apologies, I went over time, but this is quite a common disease. The manifestations are quite variable, and this was previously ignored. And I think there's interest now globally on these patients because we can improve their quality of life, especially with these endovascular techniques. Thank you. I'll stop at that point.
Thank you very much, Dr. Ngema. Your talk was quite very informative, and you have covered almost everything related to the topic. And just a comment there on your last slide where you say that this is a condition that was previously undertreated or previously ignored. If you're working in the rural communities or in the district hospital and primary health care, that still stands. This is a condition that is not only undertreated or ignored, it's also underdiagnosed because most of us don't know what to do with these patients. And hence we felt the need to just talk about it so that people would know that there is somewhere where the patient can be referred and there is actually treatment and they can get assistance with it. So there is quite a lot of questions. You've seen the questions started flowing while you were still talking. So I think there's questions on the Q&A, but would also ask people if they want to raise a hand and ask their questions directly. We can also do that, but in the meantime, we can also look at some of the questions that that are posted here. So I don't know if there's anybody who would like to raise a hand and ask Dr. Ngema their questions directly before we go on to the questions that have been posted on there. I see. Okay, I see. Yeah, Gracious wanted to know the meaning of abbreviations, to know some of the abbreviations. Yes. But I think that they will get, because they can get a copy of the slide show in PDF, then maybe we can just put the full things before we send it to them. Yeah, so I think that will be answered. And then Gracious, I don't know, do you want to ask some of your question? You want to know if the conditions are treatable, but I think Dr. Ngema has already alluded to that as well. So
if I may just add something that Dr. Machete.
Yes.
The condition is treatable, but the treatment requires maintenance as well. You will treat the patient, but you continue to keep them on the compression stockings. In fact, in our practice, we do it for life because we know recurrence is a huge issue. And if you look at patients with varicose veins, the recurrence rate at 10 years is quite more than 50% may have a recurrence. So you can treat it initially, but you need to maintain it. Thank you.
Yes, thank you. I don't know, does anybody want to ask their questions directly, or should we just answer from this?
Gracious,
Can
do you
I-
want to make a comment? Yes.
Yes, please. There's a lady I know who's having this varicose veins that are visible on the right leg. And what's happening is when she's on periods, they are so painful and they bulge. When she has sex, after having sex, they are so painful, they bulge. So
Yes,
what can she
no,
Okay.
the diagnosis,
Thanks.
is obvious. That lady has pelvic congestion syndrome. That's when they have reflux from the gonadal veins. And that's usually the symptoms you're describing are in keeping with that.
Mhm.
There is treatment for that, though it's a bit difficult, but there's treatment for that. Yeah.
is it? Where
Yes.
can the patient go?
Now,
Is it
Where are
gynae
you?
or-
Victoria?
no, the
Actually,
patient
you
needs
know why I'm so worried. Actually,
Yes.
the patient is myself. So that is
Yeah.
why I'm asking. And I've been referred to go and do a Doppler test, and there was nothing. They thought maybe it's deep venous thrombosis, but there was nothing found. I went, I think, 3 times.
No, that's pelvic congestion syndrome. I think Dr. Moela, if you'll allow,
Yeah, I think
can
the
we
way
share-
to help. Yeah, what we'll
Mm.
do, Gracious, just send us an email and then I
Yes.
will link you up with the doctor and then we take it from there.
Thank you
Thanks
very much.
for sharing. Thanks. Yeah.
Yeah.
Okay.
And
let's
maybe
have,
just to add on that, because this pelvic congestion syndrome, I've seen that the patients, some of them, they end up with the gynaes because they can have dyspareunia, they can have many gynecological like related symptoms, and then most of the time it's undiagnosed. And for you to, you have to like really exclude all other things and then see this thing. And also the issue with the periods, with the hormones, there is some theories to saying that there's hormonal influence of progesterone and estrogen imbalance can also cause vasodilatation because progesterone causes smooth muscle relaxation, which can also explain why the symptoms get worse just before when you're on your periods, because that's the time when the corpus luteum becomes active, you know, just when you are on your period. So that can also explain the problem as well.
Yes.
Yeah, maybe Dr. Machete, let's take 1 or 2 questions from the chat and then we'll come back to the hands. Thanks.
Okay, all right. Also here, Jabulani wanted to ask whether duplex ultrasound is the same as ultrasound Doppler.
It's the same thing.
It's the same thing, yeah.
Yes.
And there's also a question about the chronic use of aspirin in these patients with varicose veins or venous disease.
There's no role for it. There's absolutely no role for for antiplatelet. Some may consider them in patients who have superficial venous thrombosis, but really for somebody that doesn't have that, really there's no rule. You don't need to put those patients on antiplatelet. There's no benefit.
All right, no, thank you. There's another question here. Carl Richards, he says he has a colleague with chronic venous on the calf area, and she says it gets hard. Oh, I think this is thrombophlebitis. It says it gets hard and painful and have to use a cream to soften it. I think so. This is the patient who has superficial venous disease and having thrombophlebitis.
Yes.
So I don't know if you want to comment on that treatment for that.
No, it sounds like that. The treatment there is largely anti-inflammatories, and secondly, the underlying cause needs to be addressed. And it's usually patients who have superficial venous reflux or disease that will have that. Yeah.
All right. Let's take one hand from Jackie Mashabela. If you can unmute, Jackie.
Yes, I've unmuted.
Okay, we can hear you.
Okay. Yeah. I'm a physiotherapist, and I mostly get referrals from a podiatrist for varicose veins. And then I had Dr. Sipumelele saying that heat therapy is contraindicated in this patient. So as physios, we understand that heat therapy in most cases improves venous return, or rather vasodilation. And I understand that it's being contraindicated in this case. But then is electrotherapy, can you advise on electrotherapy? Is it wise to use electrotherapy for circulation and also improvement on the calf contraction to improve the venous return, or is it also contraindicated?
No, it's not contraindicated, it's described. But if I may tell you, there's a lot of other described techniques which I didn't talk about because they are not validated. That's one thing. And I think the unfortunate thing is, yes, we may offer the patients all of those, but the underlying pathology remains untreated. So the source of the problem is unattended. So really, you may have some benefits, but I think they probably may be better served with other modalities because that's not your conventional treatment. No. Thank you.
All right. Kanyisani, would you like to make your question or comment? Thanks.
Yes. Can I check here with patients with recurrent DVTs? And then now is coming confirmed varicose veins. Just before we have like interventions, like invasive surgical interventions, is there any benefit in anticoagulations in these patients?
Okay, thank you. You've touched a very difficult area. Now, what tends to happen is if a patient has a DVT, a significant number of those patients may develop post-thrombotic syndrome, especially if the common femoral vein was involved. Now, when they present later on, they will present with unilateral leg swelling, and your ultrasonographer may present there's a clot there. But what they don't tell you is this a fresh clot or is this an old clot? Because if it's an old clot, then the patient's diagnosis is actually post-thrombotic syndrome. It's not DVT. And I've had those problems. We still have the same problem with our radiologists here because they just tell you there's a clot. I mean, you need to give us an idea. Is this an old or a new clot? Because most patients actually have post-thrombotic syndrome. It's not necessarily the fact that it's a recurrent DVT. So what we do in our practice is we'll do our own sonar and give an idea of whether we're dealing with a fresh or an old thrombus. We also do a D-dimer, which will also give us a bit of an idea, because if they're elevated, then that is more suggestive of a fresh thrombus, although that is not necessarily specific. And if it's a post-thrombotic syndrome, then we don't anticoagulate those patients. We offer them compression and the treatment that I've alluded to, and like in this case that I presented, even angioplasty and stenting. I hope that answers your question.
Yes, thank you so much, though.
You're welcome.
Okay.
Yes, Dr. Nkema, I just wanted to say something on that as well. To say that as much as you've mentioned that the duplex Doppler is the best investigation, so the challenge is with who is doing your Doppler and the quality of reports that you get is also some of the things that are challenging that makes it difficult for you to treat the patient. Like you said, if you don't know whether the clot is old or new, it makes it difficult for you to decide, you know, and also the sonographer who's doing the sonar for you, sometimes they're unable to tell you whether there's reflux and then all of that, then now you are unsure what it is that you need to do with the patient. So that's also one challenge that we are having, and unfortunately there isn't many vascular technicians out there. I think they're only there in the academic institutions only. So some of us, we still have to struggle with not knowing what's exactly going on or just making the diagnosis.
Yeah.
Mm.
No,
So
that's the unfortunate part.
Sorry about that. Yeah, so Damachete, how do you approach these patients in a semi-rural, I don't know what you call
What we call the place where I work.
So what is the
No.
approach? Because I saw also a lot of comments around, you know, are all these patients supposed to be referred to a vascular surgeon, or how does it work? What is the process?
Yeah, so that's what I was trying to explain, to say that we do have a challenge in just making the diagnosis, because when you send your patient for a duplex doctor, you will be told there is a clot. You don't know, is there reflux? Is this physiological reflux? Is it significant reflux? And if your report is not adequate, you're also unsure of the diagnosis. So most of the time, you would just end up treating the patient, anticoagulate the patient, and then if the symptoms are persistent, like they're like, oh, it's 3 months, I've been anticoagulating this patient, this is definitely something else. And then you have to refer the patient, unfortunately, for them to get a better assessment. And most of the time, when you refer the patient, you know, like Dr. Ngema, this is a very difficult condition to treat, and it's time consuming. So you'd refer the patient. Most of the patients, some of them give up because they were, you know, sometimes patients want to see results today and tomorrow, and they feel like, I've been doing this compression, I've been doing this, but my ulcer is still there now. It's 6 months, it hasn't gone. And then they'll decide to find alternative treatment. And unfortunately, in the rural area, alternative treatment is widely available, and patients would go and try other types of treatment before they would stick with you for 2 years, you know, while you're trying to treat them. But I think most of these patients have to be referred to the vascular surgeons for them to be properly assessed and get the appropriate treatment. Because if you don't have good ultrasound, then you won't be able to treat the patient, because you won't even know where the problem is.
Interesting.
If I may come in.
Yes.
Just a brief comment. We have a problem in South Africa. There's far too few vascular surgeons, and those that are there, not all of them actually want to treat venous disease. Now, I know of institutions that don't treat venous disease, vascular surgery units. So we have a big problem, honestly, because they should be treated by vascular surgeons. Yes, there's a limited number, even those who are vascular still don't want to treat these patients. So it's a huge challenge, but really, I think it comes with personal interest, and one just needs to have them, because these patients are special.
Why are they special? Okay, but anyway, I think it's a topic for another day. It seems like it's because of is it because of there's a huge case burden? But I wanted to ask, because I saw a number of questions around cosmetic treatments, sclerotherapy, because I saw a lot of aesthetic medicine people now positioning themselves to treat. It might be because of there is no access on the scientific side. I don't know. Okay, I don't know.
No. I know that is the case, but if you look at the guidelines, they said that you firstly need to assess the truncal vein, the great saphenous vein, small saphenous, the deep system, and make sure that there is actually no pathology there. It was useless to treat those reticular veins, children of telangiectasia, if the underlying problem is not addressed. So it just becomes really a cosmetic thing, and the patient will have recurrence, obviously. And so really we need to address the top, moving downwards. You don't move from those reticular veins and treat ascending. We come from top going downwards. I hope that makes sense. Anyways.
Someone is asking about amputation. Has it ever happened that amputation becomes one of the interventions?
It has, and in my career, I've seen about 3 patients. Now, this occurs in a setting where patient has severe secondary infection of the venous ulcers, and they actually develop necrotizing fasciitis. So really there you are forced to save the patient's life. But it's usually because the ulcers were neglected, whether it's by the patient or the health workers, really, that we can debate. But I've seen it's seldom, it shouldn't happen, but it has happened.
Yeah. All right, Julia, and then maybe you'll take it from here, Dr. Machete, maybe getting to us. Julia is asking whether there's prophylactic treatment And in that context, someone was saying, as a health worker, we seem to be at risk because we spend a lot of time standing. What would you recommend prevention?
Yes.
Yeah.
No, that is important. You know, healthcare workers, we are at risk. But what I'm about to say, don't everybody has to do this. I actually had to make a decision myself because we stand so long in theater. I'm just going to wear compression stockings because you will clearly see this. Once you, at the end of the day, your feet are swollen, they're painful. So really wearing those compression stockings, even if it's minimal pressure, I mean 15 millimeters, class 1 stocking, I think it goes a long way, honestly. But that's my personal opinion. Yeah.
Are you saying you do put the stockings yourself? Is that what you're saying, Doc?
No. I'm saying I made a decision last week after I spent the whole night in theater. Said, no, I need to get them. Yeah.
Okay. Dr. Machete, have you started?
Yeah, well, I can see there's many other questions. I have one question from myself before I ask other people's question. My question is about patients with venous ulcers and doing a skin graft on those ulcers. What's your comment on that, doing a skin graft for those ulcers?
No, it is described. It is described, especially when you've got patients who've got circumferential ulcers that are unlikely to heal on their own. But the majority of those skin grafts then actually take. That's the unfortunate part, because if the underlying pathology is still not addressed, it's not going to work.
Excuse me.
And I've seen even in patients that we have treated the underlying pathology, a significant number of them actually the skin graft still doesn't take. So it's a challenge, but I think it's worth giving a try.
Yeah, I think most of the other questions are things that you've already spoken about. There's a question here about does early intervention with physiotherapy reduce the complications and recurrence? I think that's what you were in, physical activity and all of that. I think that's what you mentioned as well as part of treatment. There is a question again, the patient pelvic congestion syndrome through the gynaes, should we refer this patient to a vascular surgeon? So I think the answer to that would be yes.
No, I think the important thing is, Dr. Machet, they must go to the gynaes for them to exclude all the gynae ratios, but before they come to the vascular surgeon. And yes. I think it should be done. Once they've exhausted the investigations, then it's fine.
There's a question about any comment about the use of warfarin and clexane. I don't know in what content. Maybe Vusi, do you want to clarify your question? Because I'm not sure what the question is about, the use of warfarin and clexane in what context. I'm not sure what the question is there.
What's Vusi's name?
Vusi Mamela. Memeda.
Okay. Vusi, would you like to unmute your mic? Yes, you can speak. I see you have unmuted. All right. I don't think we can hear him. Yeah. All right. I think we can sort of get to the end of the session. Maybe, Dr. Ngema, thank you really for your time. Maybe your closing remarks, and then Dr. Machete will close the session. Thanks.
No, I'd just like to thank the organizers for the invitation, because I think this information is not out there, especially among healthcare workers. And I think as things will get better, because we're training other people, and we're trying to get people interested in this and really being active in the treatment of such, because I think it's very disabling for patients, honestly. Yeah, thank you.
All right. Thanks, Doc.
Yeah, no, so on my side, it remains for me to thank you, Dr. Ngema, for your time that you took to prepare this talk and actually come and spend more than an hour with us just to share information. I'm hoping that all the people who have attended would take this information and use it to improve the lives of our patients. And I myself also have revised a lot of things that I had forgotten when it comes to the treatment of venous disease. So yeah, and I think, like you said, we can make a difference if we all take an interest, and actually when these patients come to us, we actually pay attention and try to make the diagnosis and start the treatment and refer them accordingly. Yeah, Dr. Mawela, thank you very much for the platform. And yeah, one clinician at a time, we will improve the healthcare system in the country. Thank you very much.